What's up, guys? It's November 24, 2025. Um, you might notice the background's a little bit different than usual. That's because I'm back in my college town for Thanksgiving week, and it's nice. Um, so I'm living home with my parents for this week, and just not worrying about what to eat for dinner is nice, and I've definitely gained like 15 pounds since starting residency in July. So, you know, not eating fast food, even though it tastes good, I guess will be good for me this week. Even though I will be eating a lot of food on Thanksgiving. Um, but no, I mean life is good. I can't complain. But the purpose of this video is to go over the learning issues from my last words block. So I completed my third block of words in residency a week ago. So the week prior to last week. And then last week I was on endocrinology. Next week I'm on endocrinology, and then the following week I'm back on wards. So, residency is still hard. I'm still making mistakes every day. I'm still getting feedback that I wish I did not get. Um, but all I can do about it is try and be better every single day, you know. Um, but also something I've realized within the past few days is also have some self respect too, because I need to be better about sleeping, getting enough sleep and like eating normal food because I'm not gonna let this 3 years of residency, you know, destroy my health. Okay. Um, so yeah. My job here is to be the best doctor I can be, but it's not to sacrifice my health because I want to please some people. Um, right. So anyways, um, with that being said, let's get into learning blocks, learning issues from my last block of words. So, first of all, uh, as a resident, it's no longer enough to say this patient needs antibiotics, and the infectious disease team will decide which antibiotics, or we'll just see what the cultures say, right? Because it's right, like if a patient with COPD exacerbation, community-acquired pneumonia comes in, yeah, you're gonna probably get some sputum cultures and decide your antibiotic regimen based on the sputum cultures. Or if a patient comes in with something else, you're gonna get some blood cultures. But before, you know, those cultures come back with results, you want to start them on an empiric antibiotic regimen, and you should know in your head, even though it's very easy to look up, you should still know in your head like what antibiotic regimen do I need to start for this patient. And uh, I'm not good at that. Okay, patient comes in with, you know, I don't know, acute cholangitis. What antibiotics do you want to give and what duration? I can't freaking tell you off the top of my head. I mean, I just can't. But but it's something that I have to work on. And so, because when you're presenting on rounds and also for your notes, you need to write down this is when they started this antibiotic, and this is the expected duration. So I guess a couple like one example I can give is community acquired pneumonia, or like a COPD exacerbation, right? Secondary to probable pneumonia, right? So the empiric antibiotic coverage for that community acquired pneumonia, before you get back, possible sputum cultures or blood cultures or whatever, um, and blood cultures shouldn't be positive in pneumonia, hopefully. But before you get back those results, you want to start them on an empiric antibiotic regimen. And that empiric antibiotic regimen is a macrolide, so like an azithromycin, and um, a cephalosporin, like ceftriaxone, right? Intravenous IV, which you can hopefully transition to oral on, as you get closer to discharge, or if you see clinical improvement. And of course, just thinking about pneumonia on a broad, you know, outside in point of view, there's different, how do I put it? There's like a curb 65 criteria right, to decide whether or not the patient needs inpatient treatment or outpatient treatment, and whether or not they need oral or intravenous. But anyways, let's say the patient needs IV antibiotics. The what you will start empirically is a macrolide and cephalosporin, so like azithromycin and ceftriaxone. But then the question is, and I guarantee you, if you're an internal medicine resident, you'll get this question on rounds: what coverage are you missing with that antibiotic? Um, and so, do I have the spectrum memorized in my head? Absolutely not. But it's something I need to work on. So, for example, with azithromycin and ceftriaxone, the coverage that you're missing is you're missing MRSA coverage and you're missing Pseudomonas coverage. Um, and so, if you're worried about, if the patient has MRSA risk factors, and I don't know all of them off the top of my head, but like prolonged hospitalization, or same with Pseudomonas risk factors, then you want to add something else. So what can you add for MRSA risk factors? You can add like a vancomycin. You can add like a linezolid. Okay, what if the patient's kidneys are bad? Then you do linezolid instead of vancomycin. For Pseudomonas coverage, instead of the ceftriaxone, you can do like a Zosyn, right? Other things that cover Pseudomonas would be like ceftazidime, and the levofloxacins. So let's say a patient is on Zosyn and a macrolide and vancomycin. For the outpatient coverage, you can do like vancomycin and levofloxacin, right? Oral. Because ceftriaxone or Zosyn are intravenous, so you have to change them to oral. And don't take my word on this. I'm no expert. But like that's the kind of stuff you have to know on words. So it's always when you have a patient coming in that needs antibiotics, you should have a plan for their duration and coverage. And the good thing about words, unlike clinic, because more and more I'm starting to realize that for whatever reason, words is a lot more work than clinic, but actually not as hard as clinic. Because on words, if you come in early enough, you have time to plan these things out, right? Usually. Unlike clinic, where you usually don't have as much time to think really deeply about these things. So that's my first learning issue. Every antibiotic needs a duration and coverage. Moving on to the next learning issue. You need to get a detailed history on every patient. You can't be lazy about this. Every admission, every new patient, you need to get the full HPI. Then you need to make sure you get their past medical history, and you need to like look at every single freaking medication in their chart and say, why are you taking this medication? And then if you have time, you need to go, because a lot of attendings will want this, even if it's already written in the chart. You'll want to go over their allergies. You'll want to go over their family history. You want to go over their social history. This is stuff you learn in the first year of medical school, but to be honest, I still forget to do it. It's embarrassing, but that's just the fact of the matter. So you need to get all those things. You need to do a physical exam. There are times when I forget to do a physical exam. And then what's really important with every new admission is you need to ask the patient the question, worst case scenario, I don't anticipate this happening. If your heart stops, what do you want us to do about it? You'll ask it in a much more nicer way than that, but you always want to get the code status on every patient. So that's the next learning issue. If a new patient comes in, you need to get a detailed history, and you can't trust other people's notes. So, for example, I had a patient stepping down from the ICU. I don't remember what the reason was. I think it was sepsis. So the ICU does they do like a systems-based note instead of like the notes that we write in internal medicine. So basically what I did is I just converted that note into like the internal medicine format. And that was that. I didn't spend too much time thinking about it. But as it turns out, this patient is taking all these other medications for stuff that wasn't documented in that note, right? So you can't just trust the freaking note of the last person. You have to do a full workup for every patient. It's tedious. It sucks. That's internal medicine for you. Okay. Because like that patient, I presented that patient on rounds later in the day, and then my senior was like, well, this patient also has this, this, and this. It's like, oh, I didn't catch that. And they're also taking such and such supplements. That's another thing. Talking about taking history, supplements. You need to ask about supplements all the time. Because those are also things that can interfere with care, with disease. progression. Um, okay. Next learning issue. So get a detailed history, do a full workup on new patients. Next learning issue, I want to talk a little bit about cardiorenal syndrome. So last time uh, I had talked about hepatorenal syndrome in my last learning issues video. In this block, I dealt with a patient with what I thought was cardiorenal syndrome. So again, thinking about acute kidney injury, because cardiorenal syndrome is a type of acute kidney injury. You have three categories. You have prerenal, interrenal, and postrenal. And then in medical school, you learn this bullshit like, oh, if FENA is less than 1%, it's prerenal, and if it's more, it's interrenal. It's a bunch of bullshit. You don't ever actually like check that stuff in the hospital. Um, Normally in the hospital, if a patient has an AKI, you're going to do a fluid challenge. If they don't respond to fluids, right, which means they aren't prerenal, then you'll work up for other things like intrarenal causes, maybe get a urinalysis and stuff like that. And of course, postrenal is always going to be in the back of your head too, right? Does the patient have BPH? Does the patient have a catheter? So on and so forth. Does the patient have signs and symptoms of, ureteral kidney stones, ureteral stones, stuff like that? It's always going to be in the back of your head. But anyways, that's like the overview of AKI: prerenal, interrenal, postrenal. Normally, if there aren't obvious signs of postrenal, you're going to assume prerenal and then go from there. Now, cardiorenal syndrome is when a patient has heart failure, and because of that heart failure, they get backup of fluid into their body from the heart, right? Because the heart isn't pumping effectively, and then because you have so much overflow of fluid intravascularly in your vascular system, the kidneys sense that, well, you have a lot of fluid intravascularly, but the fluid isn't being perfused into your kidneys. And so the kidneys want more perfusion. They want more filtrate, more fluid going, more of your, fluid going into the kidneys. And so what they're going to do is they're going to activate the RAS, renin-angiotensin-aldosterone system. And that's going to cause constriction. That's going to increase, blood pressure. It's going to worsen your AKI. It's going to worsen your kidney injury. And it's also going to kind of increase preload, increase the fluid going back to the heart, make the heart failure worse, and so you have this vicious cycle. Now, I might not have explained that perfectly, but that's kind of my understanding of it. Anyways, the reason it's important to consider cardiorenal syndrome in a patient with heart failure is because the treatment for cardiorenal syndrome is the opposite of treatment for prerenal AKI, right? So prerenal AKI is like, let's say a patient has sepsis or pneumonia or whatever, and they're just not eating, or I don't know, their body's in a hypermetabolic state. For whatever reason, their volume depleted intravascularly, and so you have an AKI because you don't have enough volume. So the treatment for that is you give fluids. And cardiorenal syndrome is a type of prerenal AKI, right? But it's different than that, in that the treatment for cardiorenal syndrome is really to relieve that intravascular congestion due to the heart, not functioning properly. So if you have a patient coming in with heart failure exacerbation, that you're going to treat that with diuretics, okay? And then as their hospital course progresses, you're also going to start adding in the GDMT, the goal-directed medical therapy, right? You're going to start adding in the empagliflozin, the Entresto, the spironolactone, the what is it, the other one, the beta blockers. But first things first, you want to diurese that patient, get rid of the preload, and ideally, if the patient comes in with a kidney injury too, like with an elevated creatinine as well, it's also going to relieve that, if that's due to cardiorenal syndrome. This patient had a heart failure exacerbation. We came in, we did the diuresis, and then the next day, the creatinine went up. So I thought this isn't cardiorenal syndrome because the creatinine went up, right? Maybe he got diuresed too much, when in reality he really didn't get diuresed that much. He got um, 40 milligrams of IV Lasix, and Lasix has like a 2 to 1. So like IV Lasix is 2 times more potent than a patient's home Lasix. So the patient takes, by Lasix I mean furosemide. The patient takes 20 milligrams oral furosemide at home. So 40 milligrams IV furosemide or Lasix is basically 4 times that amount, because the IV Lasix is 2 times as potent. Anyways, I thought, okay, maybe the patient got over diuresed, right? Now they're intravascularly volume depleted. But that didn't really make sense because the patient was still having some difficulty breathing, some signs of heart failure, still had lower extremity edema, even though the lower extremity edema isn't a sign of intravascular status. But anyways, the patient was still seemed to be in heart failure exacerbation, still needed a bunch of oxygen. Um, but anyways, we thought, okay, over diuresed. Let's just hold diuretics for a day, and then the heart's gonna continue to fail and fill the fluid back up, right? So I held diuretics one day, held diuretics the second day, and it didn't get better. So then now this is weird. We're holding diuretics, letting the heart fail, fill up the body with water, with fluid, I mean, and but the AKI is not getting better. So does that mean the AKI isn't due to a prerenal hypovolemic state? So it was a confusing time. Anyways, we gave the patient fluid and the AKI got better. The kidney injury got better. So I guess I don't know, holding diuretics wasn't enough. But anyway, so cardiorenal syndrome is something you need to keep in the back of your mind, versus other causes of AKI. Okay, next learning issue. An internal. Oh, one more thing about before I get off of diuretics. So yeah, like I said, Lasix, the IV form of Lasix has twice as. Let me just Google it just to make sure I'm not lying to you guys. Okay, I don't want to. IV versus PO. Yeah, 2 to 1. So yeah, Lasix or furosemide has a 2 to 1 potency. If you give IV, you're giving twice. If you give the same dose of Lasix in an IV format, you're giving twice as much, basically. But then, like other diuretics, like Bumex, have the same potency, 1 to 1, and so it's always important to keep that in the back of your mind, as our friend Divine Intervention would have said. The conversion of the diuretics. Okay, moving on to the next thing. In internal medicine, we like to overthink. That's just the fact of the matter. We like to think about things which maybe don't even require that much thinking about, but we like to overthink. And so, in other words, something that is extremely frowned upon in internal medicine is anchoring. If a patient comes in with a certain problem and you immediately think that this is the problem, that's anchoring instead of thinking about other etiologies. So, for example, let's say a patient had a seizure. Let's say a patient had a syncopal event. What you want to do is you want to make sure you get an adequate, instead of just saying, okay, this is a seizure, we're going to restart the patient's seizure medications. You want to get a good history. You want to say, okay, if this is a seizure, why did it happen, right? Is it because of medication non-adherence? You want to make sure you ask about that. Have you been taking your medications? You want to ask about the actual episode, right? Even if the ER already got that history, you want to get that history yourself. You want to say what happened. Do you remember falling? Do you remember feeling? Did you have a prodrome? Like, did you feel dizzy before you fell? Right? Do you have a history of like feeling dizzy when you stand up? You want to look at their cardiac history, right? So even if it's like very obviously a seizure, in internal medicine, we like to overthink. Okay, we like to think very deeply about pretty much everything. So always entertain other etiologies. Do not anchor, and that's something which is relevant both for the wards and also for clinic. if a patient is syncopal, if a patient does have a history of a fall, you always want to ask the nurses to get orthostatics on them. Likewise, let's talk about pulmonary embolism for a bit. So I had a patient with pulmonary embolism. Very simple, straightforward is what I thought. My mistake. Nothing in internal medicine is like that. So this patient, I talked to her about like kind of the Wallace criteria, and I can't say them off the top of my head, but like the Wallace criteria is like the risk factors for PE or DVT or whatever. And so I asked her, have you been immobilized recently? Because at this point, when I went to go see the patient, she had already gone in a CTA, so the pulmonary embolism was already confirmed. But I just went there and got more history from her before we admitted her to the floor. Anyways, I asked her, have you been immobile recently? Have you traveled recently? Do you get up and move around the house? Have you had any recent surgeries? No, no, no. So Wallace criteria for this patient was 0, right? The risk factor for this patient's, pulmonary embolism was 0, and the patient did not have any swelling of her legs. Did not notice any swelling in her upper extremities. So where did the clot even come from, right? Because there's no DVT as far as we can tell. And so, anyways, for this patient, what I did is I did a PESI score. So there's this score called PESI, PESI, which kind of determines the severity of the pulmonary embolism, which for her it was very low severity. And then when it was time to present the patient, I just said, we're gonna let's anticoagulate this patient with heparin for 1 more day, IV heparin, and then let's transition her to oral apixaban tomorrow, and Eliquis, and then she's gonna take that for 3 months, and we can, if she's tolerating the Eliquis, later in the afternoon, we could potentially discharge her later in the afternoon the next day, or we can just discharge her the day after. But that was a bad presentation, bad plan, because again, like I said before, internal medicine, we overthink everything, okay, which is a good thing. It's a good thing. Don't get me wrong. So in this patient, we need to figure out. We can't be lazy, right? We need to figure out why this patient got that pulmonary embolism. So we, the senior resident stepped in and said, let's also order, ultrasounds on both legs, which came back negative. And then let's also, she was like 60 something. She wasn't up to date with her mammograms, which again, that's something I should have asked her, right? Are you up to date with her mammograms? Which isn't something that comes to mind, right? When you think about pulmonary embolism. But she wasn't up to date with that. She doesn't see her primary care doctor regularly. So why am I talking about this? Because cancer is a hypercoagulable state, right? Cancer is a state where you have more clotting in your blood. So anyways, we ordered a CT scan on her. It turns out this patient had some weird nodules in her lungs. So and basically we ordered outpatient follow-up for that. But and I don't know if it's cancer or not. Pulmonary nodules could be nothing. But anyways, so always think about other etiologies about things in internal medicine. So I just talked about the PESI score. We love scores in internal medicine. We love scores, and some physicians more than others. So, for example, there's like the PESI score I just talked about. And then, like, if a patient's going into surgery, if the patient's pre-op, you always want to get their risk score for that. So you'll get that through like a Gupta. There's a Gupta score. There's an NS-QIP score. You want to get their risk factors for that for pre-op and surgery. And then also something I need to work on, something I'm not very good at, is knowing which medications to start and stop. Intraoperative, perioperatively, which that's just something I need to work on. I'm not very good at that. And usually the surgeons and stuff will give you input on that as well, but you still need to know that. Anyways, so you need to do those you need to know those scores off the top of your head. I mean, you need to know when to do those scores. Gupta, NS-QIP. I still forget to do this sometimes. It's just stupid. But with atrial fibrillation, any patient with atrial fibrillation, you have to get a CHA2DS2-VASc score. And then if they don't have an anticoagulant, if they're not on apixaban, you have to ask yourself why. right? Do they have a device in the heart, like a Watchman device, which which means they don't need an anticoagulant. And by the way, I have seen so many patients. I mean, I've seen at least two patients now who have Watchman devices in their heart, and they still end up getting like strokes. Which I don't know. You know, maybe the stroke, maybe the clot came from somewhere else. I don't know, but it's just something weird that I've noticed. But anyways, you have to get a CHA2DS2-VASc score on every patient for with AFib. Another score. Let's think about acute coronary syndrome. Right, patient comes in, acute coronary syndrome. They're anginal symptoms, acute anginal symptoms, chest pain under the sternum, um, uh, relief by nitro. Right, and let's say an EKG shows like I don't know, weird changes, like some inversions here and there, but it doesn't show any STEMIs. It doesn't show any ST segment elevations, and then the troponins are slightly elevated. Okay, what does this patient have? Elevated troponins, angina, but no STEMI. That's called an NSTEMI, right? And then there's different types of NSTEMI, which quite frankly I don't know off the top of my head. Something I need to look into. But anyways, patient with NSTEMI, you have to know like the scores you have to do for that. So a patient with NSTEMI, you have to do a TIMI score, right? And then if the TIMI, TIMI score, and then if the TIMI score is high, then even if the patient has an NSTEMI, they're going to go get cathed. They're going to get percutaneous coronary, whatever that stands for. They're going to get cathed. Um, if a patient's TIMI score is low, they're not going to get cathed. They can be treated with um, anticoagulation, antiplatelets, the other things, high intensity statin, um, nitrates. Um, if a patient has an intermediate TIMI score, then you want to do a GRACE score. So, again, scores. We love scores in internal medicine. Um, this is just kind of random, but let's say you start a patient on apixaban. So, like, I had a patient with a deep vein thrombosis. We started the patient on apixaban, and then we were going to discharge the patient. But the patient also had underlying iron deficiency. The patient had chronic normocytic microcytic anemia, um, which was determined to be iron deficiency. Should you discharge the patient on iron? No, because the iron makes the stool black, and you just started the patient on apixaban. So how are you going to know if the patient is bleeding or not, right? So again, you hold iron if you're worried about bleeding. Um, okay, if you go into a patient's room and they mention that they have some kind of new pain, like left ankle pain, you again, if you're gonna be, you can be lazy. Like I like to be lazy sometimes, and you can just be like, this patient's complaining, whatever, they're fine, forget about it, right? Uh, but that's not what you're supposed to do. If a patient mentions new symptoms, even because you'll notice, like once if any of you aren't residents yet, patients like to. There are some patients who just like to talk a lot, and they seem to have new symptoms every single day. But anyways, you have to take that seriously. So, I had a patient with left ankle pain, and this patient was a hospice patient. Well, like a semi-hospice patient, kept changing his mind, but which is understandable. And anyways, he mentioned he had this new left ankle pain, but we didn't have this patient. So, anyways, I was like, okay, let's just I'll order. This patient already had a bunch of morphine. And by the way, this patient is hospice, but like not on death's door. We're trying to get rid of this patient. Like this patient is going to get discharged, right? Anyway, so the patient already had a ton of morphine for osteopenia in his right knee. Is that like an indication for morphine? I don't know, but the patient was hospice, so whatever. So, anyways, I was like, okay, let's add something else to his pain regimen. But no, this patient has a left ankle pain, okay, and they're not anticoagulated because they denied, uh, DVD prophylaxis, right? Like you need to think about that. So I ordered after talking with attending and attending basically saying I'm not outright saying it, but making the impression that hey, you idiot, you should have thought about this. I ordered Doppler ultrasound of that ankle, and luckily there wasn't anything there. So I think it was just from him lying down in bed and not moving his leg, but Again, always think about things, right? That's what we do in internal medicine. We think. So, um, telemetry. If a patient is on telemetry, you always need to review the telemetry. I suck at reading EKGs, but you always have to look at it. And basically, what you want to do is, if you're on Cerner, you want to go to the general review tab and you want to look at the strip. You want to look at the graphic trend. Something to keep in mind. Always look at the tele. If you don't think the patient needs to be on telemetry, then take the patient off of telemetry. Uh, with patients who have COPD exacerbation, you want to continue their home inhalers. Which inhalers are these? I think you just need to memorize, like, because you're not going to use the exact same inhalers the patient uses at home. The hospital always uses some inhalers. So the inhalers you want to use are budesonide, formoterol, rivafenacin, and duanebs. And duaneb, I believe, is like albuterol tiotropium. Let me just Google that really quick. Hypertropium. So right. So right. So you want to do duanebs, which is SABA, small short-acting bronchogenic agonist, aka albuterol, and SAMA, short-acting muscarinic antagonist. Um, so that's ipratropium. Then you want to do rivafenacin. Let me just Google what that is because I, I I, um I noted it here, but I didn't write down exactly what that is here. What is it? LAMA, right? Long-acting muscarinic antagonist. Then you want to do formoterol. I believe that's a steroid. Let me just Google that, make sure I'm not giving anybody wrong information. No, it's not a steroid. It's a LABA, long-acting bronchogenic agonist, not antagonist. And then budesonide. Budesonide is the steroid, I think. Right, that's the inhaled corticosteroid. So every patient with COPD exacerbation, you want to have them on those inhalers. And you're going to see a lot of patients with COPD exacerbation in internal medicine residency. Just have it memorized. They should be on duanebs, rivafenacin, formoterol, budesonide. If a patient has recurrent COPD exacerbations, you always want to consider if the patient has uh, chronic bronchitis or not. If they do have chronic bronchitis, then they need to be on chronic azithromycin. So the criteria for chronic bronchitis is 3 months of productive cough and 2 successive years. Okay. Those are the learning issues from block 3 of wards in internal medicine. And I'm working, man. I'm really doing my best out here, trying to get better every day. But I'm just doing my best. I feel like I'm more on every day when I'm in the hospital, but I'm just doing my best. I'm trying to memorize and remember these things, these learning issues, so that I don't make the same mistakes again. And yeah, so residency is still stressful, but this is a good week. I'm back home for the Thanksgiving week, so I'm gonna try my best not to stress too much about it. So, all right. With all that being said, you'll have a good one. Let me know if you have any questions. Thanks.